So from kidney we are entering to the ureter, the output of kidney which is traveling through these with pipes and going to be stored in the urinary bladder. Today we are going to cover this ureter and along with the urinary bladder, some salient features which is important for us. Now whenever describing this ureter, is kind of a pipe which is a tube like structure extending from the kidney and going to the urinary bladder. It has a rough length which is around 10 centimeters. It has three basic parts can be described of. One part we call them as the renal pelvis. Once pelvis ends, then ureter begins, and then we have this particular ureter which can be divided into three segments. We call this ureter in three parts, like abdominal part, then it goes to the pelvis, we call them as pelvic part, and once it pelvis, it makes a curve, goes to the urinary bladder, we call them as vesical part when it is piercing through the musculature of the urinary bladder. So three parts we can describe this particular ureter having a length of 10 centimeters. First is abdominal part. As you are describing, this abdominal part ureter is running on the posterior abdominal wall, that means it is retroperitoneal. So is the kidney. So kidney is the posterior abdominal wall, the tube drops down from there, which is the retroperitoneal posterior wall or posterior abdominal wall structure. So it drops vertically and it enters to the pelvis, crossing the pelvic brim or pelvic brim. We talked about this particular pelvic, we call them as pelvic inlet, and this particular ureter, as it is going down to this particular posterior abdominal wall, it is related to the muscle which we call them as psoas muscle, and psoas muscle has a covering, we call them as psoas fascia, and this particular psoas fascia along with the psoas muscle has an attachment on the vertebrae, we call them as transverse process of the vertebrae. So it is basically transverse process of the lumbar vertebrae and this psoas muscle, psoas fascia into this particular structures, this posterior abdominal walls ureter or abdominal part of the ureter is related. Then it goes down, drops into the pelvis, crossing the pelvic brim. Once it crosses the pelvic brim, then we call this ureter as pelvic part of ureter. Now the pelvic part of the ureter is important for us because in male and the female the organs are different. So that is why it has some relationship, some anterior relationship, some posterior relationship to it. So this particular ureter, as it is goes down to this particular pelvic cavity, it is having two parts. One part we call them as vertical part, that means it goes vertically and then it curves around the lateral wall of the pelvis. So it has a vertical curved part going down along the lateral wall of the pelvis, little bit moves laterally from midline to like this, and then it have a oblique course, then it crosses, then it comes closer or goes medial. So we have this particular course of the pelvis or pelvic part of the ureter which is going in a two different directions. We will be coming this particular part as we are showing here. So it is a retroperitoneal, sits on this particular psoas in the abdominal part and crosses this pelvic brim and crosses this particular bifurcations of common iliac artery or bifurcation of the internal iliac artery as well. So it descends to the pelvis. Along with this particular length, it has some constrictions. We will be coming to this constriction. First, we have to understand the course of it. This is what you are seeing here is the spatial X-ray of the kidney along with this particular ureter. So this particular thing we call them as urogram. So dye is given through mouth or through injections, and then this particular pictures are taken like X-ray pictures, and you are visualizing this particular outflow part of the kidney like calyces, minor and major, then pelvis, then ureter, it is going down. So this is how it is going down into right side, left side along with the pelvic part. You can see this course in the pelvic abdominal part pretty straight, and then it is going down crossing this pelvic brim like here, and then it is curving, see, on going to the lateral wall. Going to the lateral wall, then it is moving medially. This is how it is going. So this particular part or course of this particular ureter is like this: abdominal part, then pelvic part. Pelvic has a vertical, oblique or vertical part, then we have a oblique part which is crossing. Then eventually it pierces this urinary bladder which is lying somewhere here and goes to intramural part of the bladder, that means pierces the muscles of the bladder, gets inside the cavity of the urinary bladder. So this is having, so entire length is 10 centimeter. Having this particular length is divided into 3 parts: abdominal part, pelvic part, and intramural or vesical part. That means inside the bladder it is placed. The length of 10 centimeter approx. Now, this particular part as it is going through this particular pelvis, this pelvic part of this particular ureter is important for us because it crosses number of structures getting into this particular region. So once it crosses this particular pelvic brim, it gets this particular bifurcations of the common iliac, which is a little high up. So common iliac artery, it crosses that common iliac, then it goes to the lateral wall, and in the lateral wall it goes to related to this particular external iliac and internal iliac branches. Obturator artery, obturator nerve goes in front of that. It drops down further and goes to this particular ischial spine, and that part it turns bent, reaching to the ischial spine. In the hip bone you have this spine, ischial tuberosity, ischial spine, reaching that particular point, the ischial spine, its vertical course is stopped. Then it curves to medially, and medially it has this urinary bladder placed. It pierces the urinary bladder like this in this particular part and becomes intramural or vesical portion of the ureter. So this is how these particular things are coursing and related to these particular structures which are related to it. So this particular course which is present in the pelvis is different in case of the male subject and different in case of the female subjects. So that's what you have to understand. The anatomy is more complex in the female subject because they have number of more structures present in this pelvic cavity than the male subjects. In male subjects is pretty much straight, easy. So we go to the male subjects, then we come to the easier part of female, difficult part, which is female subjects. So this is ureter coursing down, crossing this particular bifurcation of this particular common iliac artery. Then it gets the external iliac, internal iliac. Then internal iliac also bends into anterior posterior division. Those division branches are related or crossed by this particular artery, ureter. Along with that, the nerves which is present in here, you have seen this particular nerve which is present to the psoas muscle and obturator internals, externals or obturator nerve. They are crossing over, going to this particular obturator foramen. It crosses those nerves as well as it is going down. So in case of the both male and the female, it crosses these arterial branches and nerves as well. What artery? This CIA, common iliac, internal iliac or branches of internal iliac which is present, and as well as it crosses over these nerves which is present in medial, goes to the medial to lateral direction like obturator nerves. These are common in male and female subjects. And then what happens in the male? It goes straight till this particular ischial spine, lateral wall of the pelvis. It goes to straight over here till this lateral wall of the pelvis is reached. Then it turns medially and pierces the bladder. Pierces the bladder. In that part we call them as trigon of the bladder or external trigon, and then gets inside this intramural part which has an oblique course, short oblique course, and opens into the cavity of the urinary bladder. So this is the course which is present in case of the male subjects. In case of the female subjects, we have number of structures present in here. So we have this particular uterus, and we have this ovary, we have this connecting tube between the ovary and the uterus, we call them as fallopian tube. So these are the three structures. Additionally, in case of the female, it is there. And if they have the three additional structures, they have three additional blood vessels which are present to it, which are going to feed this. So we have three structures. Along with these particular feeding structures are there, like the blood supply to the ovary, ovarian vessels, blood supply to the uterus, uterine arteries. They are also additionally present along with the structure itself, which is present in case of the female only subjects. Now, and the connecting tube, we call them as fallopian tube, that is also present to these particular regions, which is predominantly present in this particular part. So this particular part or pelvic part of this ureter which having a relationship which is complex compared to the female subject. So it crosses the same structure which is here, blood vessels, nerves, which is common. Additional to it, we have this particular number of structures. That means blood vessels which is going to supply the ovary, which is related to it, and this particular like a structure fallopian tube which is related to it. The blood supply to this uterus, which is known as uterine artery, they are also related to it. So these structures need to be considered whenever you are seeing this particular ureter in pelvis in a female subjects. So it crosses this particular pelvic brim, which reaches superficially to it. These structures, bifurcation, superficial, external, lineal, common iliac arteries, vesical arteries, which is going to supply the bladder, obturator vessels, vesical arteries, rectal arteries, they are common. In addition to it, it runs on the posterior subject, on the female, runs on the back side, it runs on the boundary of this part, we call them as ovarian fossa. That means where this ovary is placed, that particular point we call them as ovarian fossa. So, it runs behind the ovarian fossa. So, which we have this particular additional work to understand whenever you are dealing this particular ureter in this particular subject. So, if you are dealing with this ovary for surgery, you have to remember that blood supply of the ovary coming from the ovarian artery need to be taken care of when you are doing surgery. When you are going to do surgery related to this particular uterus, you have to take care of the uterine artery or uterine vessels when you are dealing with the surgeries. This is what comes in here related to this particular organ problem. So, this is what we are talking. Now, reaching to this particular posterior part in the bladder. So, the point where this particular ureter pierces here, we call them as trigon of the bladder. Now, trigon of the bladder is of two types. We call them as internal trigon and external trigon. External trigon means the externally when you are seeing that part where these ureters are piercing. So, that point we call them as trigon. Why call them as trigon? This is triangular space. So, this is urinary bladder that you are seeing on the back side. So, this is what you are seeing here in the black is ureter. They are coming from above and they are piercing here, this point. So, this point they are piercing, and this point where this particular bladder narrows down, we call them as neck of the bladder. So, if you draw an imaginary line joining this particular ureter right and left and this particular neck region of the urinary bladder or narrow region of the urinary bladder, we get a triangular space. So, this triangular space externally we call them as external trigon of the bladder. So, this particular edge of this external trigon, right and left edge of the urinary bladder, we have this particular ureter piercing. In case of the female subjects, you see that this particular ureter, as it is piercing, it comes across the structure which is coming here, looping here. This is a male structure which is coming over here. We call this structure as a vas deferens. So, this vas deferens which is coming from the testicles. So, testicles is bringing the sperm which is coming through here. This part we call them as vas, and this dilated part of the vas we call them as ampulla. So, this ampulla, once it ends here, it has a gland here. We call them as seminal vesicle. So, this duct of the seminal vesicle and duct of this vas deferens joins here. It forms a common duct. We call them as ejaculatory duct. That particular duct is present in the posterior side of the bladder. So, when this ureter is piercing here in the male subject, in the posterior surface of the bladder, before it pierces, on top of it you see that this particular vas is crossing over. So, this structure which is related to this particular male subjects, which is related to the pelvic region of this ureter, is that when it pierces this particular bladder, this particular vas deferens crosses over from lateral to medial. So, this is the lateral side, this is the medial side, right. So, the vas deferens comes from the lateral side, makes an entry from the side and crosses and drops down medially. So, the vas is crossing from lateral to medial in this point, which is related to this particular ureter once it pierces in the male subject. Similar to that, we have this uterus, we have the fallopian tube, and you have the uterine vessels which is related to it. Now, we see that this is the relationship of the ureter with this uterus and the blood supply. So, this is the uterus, this part we call them as fundus, then we call this part as a body, then we call them as cervix and vagina, so on. So, this particular part we see that this is an artery which is entering here, this artery which is flagging over here, this artery we call them as uterine artery. So, this uterine artery is coming from the lateral side. The uterine artery is a branch of internal iliac artery coming from lateral side, and then it goes medial. So, it is crossing from the lateral wall and getting in here medially, piercing it. So, this structure which is traveling along in this particular pelvic region coming from lateral side to the medial side, lateral wall to this particular medial side, crosses over this ureter. So, how this particular ureter is crossing? This ureter is lying on the posterior side or back of it. So, this ureter which is running from the back side is crossing over and going in here, and then crossing over is going anterior to it. So, this is uterus. In front of here we have a bladder, and back to it we have the rectum. So, this ureter was there on the back side of it, then it lateral wall, then it moved, it has to cross over this uterus, then it can end up into the urinary bladder. So, it has to come from the back side to the front side. So, this back side and front side movement of this ureter you have to remember when doing pelvic surgeries in a female subject. So, this surgery you are doing a surgery which is related to the uterus. That means you are removing the uterus, for example. Now, if you are removing the uterus, you have to stop the blood flowing through it. Then you have to clip the arteries so that blood is not more flowing to the organ. So, then you are ligating. What artery you are ligating? The artery which is feeding the uterus. What artery is feeding the uterus? Uterine artery. Now, uterine artery, where are you going to get this? This is the uterine artery. You are going to clamp this uterine artery, or you are going to clip it. So, this point you are clipping this uterine artery, and see that nearby what structure is lying? Ureter. So, where the ureter is coming? Because it is coming from the lateral side and it has to reach forward, go anterior to it. So, it has to cross. So, as it is crossing, it is going under the uterine artery. So, when you are clipping, you have to be careful not to clip this particular ureter along with the uterine artery. Am I clear? So, whenever you are closing this artery, you will make sure you are closing this artery only. By mistake, if you close this artery and along with the ureter, that means you are clipping these two structures together. That means you are closing this ureter and the uterine artery as well. So, what you are doing? You are closing the outflow of the urine. That means that kidney is no more can work, no more can produce the urine, is delivered to the urinary bladder. Then what is going to happen? That is going to stay within this kidney. What is going to happen to the kidney? It is going to get bigger, blow up and burst and problem. So, that is what we call them as this particular problem related to this particular this structure can be injured at the pelvic brim when you are doing surgeries or clamping of this particular surgery during this surgery related to this part. The same thing can happen in case of the surgery of the ovary as well. Why? The same thing. The ovary is related to the back side of it. We call them as ovarian fossa. So, this particular ovary is lying here. You see that ovary is there. Where is the ureter? Is lying posterior to it. So, it is making a posterior structure relation on the fossa of the urinary fossa of the ovary. So, again you are doing a surgery into this particular ovarian region, ovarian vessel you are going to tag or vessel you are going to clip. While clipping this ovarian vessel, where is the ovarian vessel? This is the ovarian vessel. You are going to clip this, and again by mistake you are clipping this ovarian mistake and same side ureter as well. The again same fit. So, while doing this particular surgery, you have to remember this relationship, and they ask this question because that is the point. We have to be watchful. Unless you know that, we may injure that. Accidental injuries, which is pretty common because there is not a big space, very narrow space, and very narrow on the posterior and posterolateral wall of the pelvis. You have so many structures. What structures you have? Anteriorly, we have the bladder, then you have this rectum, and further anterior in between you have this uterus. So, three structures crammed in this particular space, very narrow space, very delicate structures are going in this particular regions. So, this is an important relationship that you have to keep in mind related to this particular relationship of the ureter in the pelvis. In case of the male, in case of the female, the ureter which is coursing from this particular kidney and ending to this particular urinary bladder is coming into three different parts: abdomen, pelvis, bladder. Pelvic part in male and a female is complicated part. Pelvic part is complicated related to this male and female subject, both of them. Why? Because in case of this particular region, we have a number of structures related to it. What structures is related? So, it crosses in front of these particular vessels which is lying in front of them, and on the posterior side it has a number of structures related as well. What structures related? In case of the female, we have this uterine arteries, ovarian vessels which are close by. Why is this structure is close by? Because this particular ureter is on the posterior abdominal wall or lateral abdominal wall, and this particular structure where it is draining, which is the anterior most. So, if these particular structures are this one, three of them, So, this is the rectum, this is the uterus, and this is the urinary bladder, and my structure is over here. So, it has to go on the lateral wall first, bypass this, and then it has to cross this structure to reach here. So, while it is crossing, it has to encounter this particular relationship of the uterine vessels and ovarian vessels. Numerically, this particular structure, in case of the female subject, it lies or makes the posterior boundary or posterior relationship of the region where the ovary lives. Where the ovary stays, we call them as ovarian fossa. So, this particular posterior structure of the ovarian fossa is formed by the ureter. So, whenever you are doing surgery to this particular ovary, we have to take care of the blood supply to the ovary, which is ovarian vessels, which is related to this particular structure nearby, which has to be carefully dealt during surgery whenever doing surgery in the ovary. Similar to it, the uterus. So, this relationship of this ureter and the uterine artery, you have to keep in mind related to this particular crossover. Okay. So, that is why this particular ureter is having a very close relationship of these so many structures, blood vessels and the structures which is present to it, male and female. This is the male side, this is the female side. Addition to it, we have the male structure which is crossing from lateral to medial, which is vas deferens, which you are seeing here. So, this vas is coming from the superficial to inguinal ring to deep ring and getting to the pelvic wall, lateral pelvic wall, then it crosses on the back side, goes on the back side of the urinary bladder to meet the seminal vesicle to form this, and so is this particular ureter, it is dropping down. So, this vas is crossing anterior to it. So, if you have to do any surgery related to the vas into this particular pelvic region as well, you have to be careful, but surgery to the vas is less commonly performed. Compared to that, we have a more frequent performing surgery for the like a hysterectomy surgery or ovariotomy or ovarian related structures. So, which is more commonly been practiced, that is more commonly been tested in examination. Clear? So, this relationship is a very big star mark for you, not for the exams, for your life as well. If you will end up in the obstetrics department, this course you will be doing this every day for surgery related to this ovary or the cervix or uterus. Clear? So, this is about the ureter, and the course complexity lies in the pelvic part of the ureter. So, prepare as a short note on the pelvic part of the ureter. Now, coming to the clinical part, which you seeing here, the course of the ureter, along with that it has 3 narrow points. We call them as constrictions of ureter. There are 3 narrow spots where this ureter is narrow, physiologically narrow, that means it is designed like that. So, this narrow point is a beginning part where this particular ureter begins, that means where the pelvis ends, the ureter begins. Where the pelvis ends, the lower pole of the kidney, where the pelvic end, pelvis part of the ureter end and ureter begins actually. So, that particular we call them as pelvi-ureteric junction. In short, we call them as PUJ. That is a point which is narrow. Second, where it crosses the pelvic brim, that means from abdomen it is entering to the pelvic part. So, when it is crossing that part, it is narrow. Third part, where it pierces the bladder, that means when it enters to the bladder from the external trigon. Remember that part we mentioned, where it is piercing that point, we call them as external trigon part, where it is going there. So, this particular part which is piercing bladder, we call them as vesicle. So, we call them as vesico-ureteric junction. In short, we call them as VUJ. So, PUJ and VUJ, these are the narrow spots, natural physiological narrow spots where it is narrowed, and addition to it, when it crosses over the pelvic brim, you know the pelvic brim, the circular thing, right. So, that part is narrow. Now, what is the significance? Now, you have a stone develop in the kidney do not want to keep it, it throws it out. Now, the stone is dropping down from the kidney through this particular urinary bladder, it is going to, it coursing to the urinary bladder. So, it is coming through this particular this pipe, what pipe? The ureter. So, as it is going down, these are the narrow spots where it can be stopped. So, if it is stopped at that point, It will be blocking the tube at that particular point. Yes or no? So if it is blocking the tube, if you have the stone impacted on that part, how the urine will be going? It cannot go. So urine will be pushing pressure on it. So it will be pushing pressure. The peristalsis of this part will be more. So it will be doing more constrictions. What happens if it is going to do more constrictions? বেরোবি না, জোরে চেপে চেপে বের করে দেবো. So the organ is going to feel pain, and that particular pain we call them as ureteric pain. How this nature of the pain is? It comes and goes. We call this colic pain. Comes and goes. It has a contraction, then relaxation, contraction and relaxation. That means it comes and goes. So this particular points, the stones may get naturally or physiologically get stuck. Where are the narrow points? 3 points, 1, 2, 3. So it may get stuck at PUJ, pelvic brim, or BUJ. So these are the points we will be looking into this particular picture. You know where is that particular point? PUJ. Alright, this is in nearby PUJ. Then pelvic brim somewhere here, and then BUJ. So these are the points you will be looking into. These are the maximum chances where this stone may get stuck there, because rest of the point is wider. So the narrow joints where this traffic gets stuck, so this particular stone can get stuck there. Now if you have this particular stone stuck at this particular points, what is going to happen? We have going to feel pain, ureteric colic pain. What do you mean colic pain? Spasmodic pain, comes and goes. So this patient is going to say that হচ্ছে আবার থেমে যাচ্ছে, আবার খানিকক্ষণ বাদে হচ্ছে, ব্যথাটা হচ্ছে. Now this particular region is supplied by the nerves. The nerves which is supplied here is sympathetic and parasympathetic nerve. The sympathetic domain which is coming over here is coming from the nerve which is coming from the T10 to L1 segment. So that nerve supply, sympathetic chain supply, which is supplying this particular region, is coming from the spinal nerve segment T10 to L1 segment. That means T10, T11, T12 and L1. That means these 4 nerves are going to supply this. So what is the dermatome? T10 dermatome, umbilicus. So where the pain will be there? Around the umbilicus. And where the L1 domain? In the fold of the thigh, here we call them as groin region. So between here to here you have pain. So this particular pain radiates from this particular umbilical region to this particular fold of the thigh region here. So we call them as backside as loin. This T10 dermatome, we call them as loin to groin pain. So the pain is be spasmodic in nature, restricted from T10 to L1, backside to kidney region to the groin region. Groin means inguinal ligament, that region. Clear or not? So this is how we can assess it with the pain, nature of the pain, depending on how much duration it is. সারাক্ষণ ব্যথা করছে, কি করছে না জিজ্ঞেস করতে হবে, জিজ্ঞেস করলে বুঝবে। পেশেন্ট বলবে না সব সময় করছে না, মাঝে মাঝে করছে, আবার চলে যাচ্ছে, आ रहा है फिर छोड़ रहा है, फिर आ रहा है, फिर पे पकड़ पकड़ के पटक पटक के झटक झटक के आ रहा है, बिजली की तरह आ रहा है. So it's a kind of sharp shooting pain, loin to groin, spasmodic in nature. Is it painful? Yes, very painful. কত ব্যথা হয়? খুব ব্যথা, ঠিক আছে? So these are the things that matters for interpreting this particular ureter which is related to it. Okay? Now blood supply to this ureter, we do not have any blood supply to a ureter which is dedicated for it. That means we do not have a artery which is dedicated to the ureter. So what it does, it gets the regional supply. That means when it goes to the kidney, it gets the blood supply from renal artery. When it goes to this particular like abdomen, it gets the abdominal aorta branches or branches, lateral branches from the abdominal aorta. When it is pelvic region, it gets the blood supply from the iliac arteries. When it close to the gonads, it gets the blood supply from the gonadal arteries. It goes to the close to the bladder, it gets the blood supply from the vesical artery. So, it shares the blood supply from the organ it is getting nearby and takes it from there. So, local supply. So, it do not have any artery which you call them as artery to ureter. Rather, it is taking a branches or supply from this. So, it has a small branches coming from the regional supply. You understand the difference? Regional supply, খাবার নিয়ে যাচ্ছে না, যেখানে গাড়ি দাঁড় করাচ্ছে, খিদে পাচ্ছে, খেয়ে নিচ্ছে, আবার উঠে পড়ছে, পরের স্টেশনে যাচ্ছে, আবার কিনছে, খাচ্ছে, চলে যাচ্ছে। ওর কোনো ঝামেলা নেই, বাড়ি থেকে কিছু রান্না বান্না করেনি, ও তুই যা করছিস ভাই দিয়ে দে, আমি চলে যাব। Right? So this ureter having got clinical importance related to this particular part, along with this pelvic part of the ureter, you come prepared in the male and female subjects. Very important structure that is related to this organ, because it's have a intrigue relationship for the closeness of the structures which is related to the pelvic organ itself. When you going to study this ovary, or if you have studied already, you study this particular like boundaries of the ovarian fossa. In the boundary of the ovarian fossa, it has lateral, medial, inferior, superior borders or relationship, and the posterior one of the boundary is related to this particular ureter. So this particular posterior boundary of the ureter or the ovary, the ovarian fossa relationship, and tested in examination. Where the ovary lies in the practical, they say that, and they want to know that whether you understand this particular relationship of this particular ovary or ovarian fossa with the ureter. Why? Because this structure we have told you so many times, because this relation. Now coming from the ovary to the urinary bladder. Urinary bladder, which is present in the abdominal pelvic cavity, right? It is lying in the pelvic space. Now, when this particular urinary bladder is there, it's a hollow viscous. That means just like stomach, it has two stages. That means it may be empty, it may be filled up. So when it is empty, it is collapsed. When it is collapsed, it is lying in the pelvic cavity. When it is distended, that means when it have holding urine, that means it is distended. When it gets distended, it climbs to abdomen. So it becomes to the abdominal organ when it is distended, and when it is collapsed, it is a pelvic organ. So we can call it as abdominopelvic organ depending on the state. Agreeing? Agreeing with this concept? So when it is in a stage which is collapsed, this is in a pelvic organ or 100% pelvic organ. When it is distended, it is in the both spaces, pelvic spaces as well as abdominal spaces. So we can call them as abdominopelvic organ, or you can narrate it whatever the concept we are saying. Now this particular area have got surfaces and some borders are there, some parts are there. So it has got three parts, as I say. It has a pointed part, we call them as apex of the bladder, which is related to the symphysis pubis. So the apex of the bladder is there. I am considering it as a collapsed bladder. So it has three parts. We call them as, it has a tetrahedral shape when it is collapsed, and it has three parts. We call them as apex. Apex is a part or pointy part which is related to the symphysis pubis, and it has a direction towards umbilicus. That means it is directed like this, towards the umbilicus. So inside the pelvic wall it is there, it is directed towards the umbilicus region. Then it has a posterior side, we call them as base, base of the bladder. The base of the bladder, in case of the male, we have the vas deferens, we have this particular seminal vesicle, we have the formation of the ejaculatory duct which is present in that particular part. So base, which is posteriorly related. Posterior to that we have the rectum. So the rectum side of the bladder, we call them as base of the bladder, and the symphysis pubis side, apex. Now this particular structure is narrowed down. So the point which is narrowed down towards this urethral end or output end, we call them as neck. So it has three parts. Pubic part, we call them as apex. Rectum part, base, and urethral side where this output is there, neck part. Neck in case of the male is having additional gland, we call them as base of the prostate or prostate gland. So three parts are there, we can describe it. It has two surface, one is above surface, superior surface, and one is inferior surface. Now inferior surface is related to the lateral extremities as well. So we call them as right and left inferolateral as a continuous structure. So inferior surface which is continuous with the lateral, we call them as inferolateral surface. So how many inferolateral will be there? Right inferolateral, left inferolateral, and superior one is the superior one, and superior one is continuous posteriorly with the base of the bladder. Clear? So this one which you are seeing here, this is what we are seeing here, the bony pelvis. This is vertebra, this is sacrum, this is urinary bladder, this is a male subject. This surface above, superior surface, this is apex directed toward this here. So this is directed to the umbilicus over here. So this is apex. So this part we call them as apex of the bladder. This part which is related to the rectum back side will be base. This side which is related to the urethra we call them as neck. So three parts are there. Surfaces, this one which you are seeing here related to this particular abdominal side which is seeing above, superior. This side which is down, inferior. Inferior side is related to the lateral side as well, they are together. So we are not separating them because they are together. We call them as inferolateral surface. Base and two surfaces in a collapse stage. Now once this particular organ is distended, this posterior surface blends with the superior surface, and this one inferior surface and inferolateral surface which is together gets out, we call them as anterior inferior surface. This anterior one becomes inferior surface, moves up, becomes anterior. So we call them as anterior inferior surface. We will come into it. So this is the bladder which you are seeing here. This is what you are seeing here is the apex. Apex is having an attachment of a ligament. We call them as median umbilical ligament which is attached to it. So this medial umbilical ligament is a remnant, developmental remnant. We will talk about in this ligament in embryology development class. Opposite to the apex which has posterior side which is related to the base. Base how can be identified? Base is pierced by this structure. What is that? Ureter. Ureter is piercing the point of the bladder, we call them as trigon or external trigon. And this narrow point where the urethra begins, we call them as neck or neck of the urinary bladder. So these 3 points are there. This surface which you above, superior surface. This sides which you see here is inferior surface, collapsed, inferior and lateral merging together, inferolateral surface. So this is how it looks like in case of this particular bladder if it is collapsed. Compared to that, this particular bladder may be filled up, little bit may be moving up. So when this particular bladder is filled up, it moves high and goes above the symphysis pubis. Then it becomes pelvic organ. Once it crosses this pelvic brim, goes above, we call them as abdomen. So part of the organ is lying in the abdomen, and the pelvis we call them as abdominal pelvis. Now you see that this inferior surface is moving up, and this inferior surface is becoming a surface which is new one. So inferior surface becomes anterior one. So this is anteriorly related. So this one, we call them as inferior anterior surface, and superior surface continues with the bladder, we call them as posterior superior surface. So we can change this depending on the stage. Likewise the stomach, we remember the stomach, we call the stomach as anterior surface, posterior surface, then it becomes anterior superior and posterior inferior when it is distended. Same thing happens here, collapse stage or depending on this stage. Now if you cut this particular urinary bladder, we find this particular space, that's what we are talking about. So this ureter is piercing into this particular substance of the urinary bladder. So this part we call them as intramural part of the ureter, it coursing obliquely. So it comes from here piercing posteriorly and then it runs obliquely, it makes a flap, so that it creates a valve like structure or valve like architecture, so that it allows the urine from coming from the ureter to the bladder. Or else if you do not have a valve or just like structure, if this particular bladder gets filled up, it can regurgitate black, right. So, it can backflow to this particular tube over here. So, that thing is prevented by the oblique course of the intramural part of the ureter. So, this is little bit curved here and then curved here. So, it creates a flap, so that the urine is kept in urinary bladder, is not overflown back to the kidney back whenever it is distended. But again, so between this particular piercing point of the ureter, right side, left side, and the urethral opening, we find another trigonal space inside the cavity of the bladder. So, this one which is corresponding with the external trigon, we call this one is internal trigon. So, internal trigon has a boundary, it is bounded by this particular ridge, we call them as interuteric ridge between the ureter, and between the ureter to this particular urethra we have another ridge, another arm. So, it makes an imaginary triangular space, we call them as trigon of urinary bladder. Now, this trigon is sitting inside the urinary bladder, we call them as internal trigon. Likewise, we have a trigon on the external side of the same structures which is making it, we call them as external trigon of the urinary bladder. Clear? So, this external trigon and internal trigon are important for anatomical facts or embryological facts. That is different, we will talk later. Now, coming to this particular bladder, this apex is anchored to this particular laminate, we call them as median umbilical ligament. You must remember this medial umbilical ligament, because if the organ is given to you, this one is helping you to identify the apex of the bladder. So, medial umbilical ligament is attached to this point, we call them as apex of the bladder. Opposite to it, we have this ureter, that means this is the base of the bladder, that means it is a posterior side. Base can be divided into upper part and lower part. Upper part is related to the rectum and the peritoneal covering. We have in between them, we have a pouch existing between the bladder and rectum. We call them as rectovesical pouch in case of the male. In case of the female, we have the uterus lying in between them. We call them as uterovesical pouch or uterovesical fascia or space. So, the upper part of this posterior side is related to this particular structures and lower part is related to this particular structure. What structure? The vas, the seminal vesicle, these are related to the posterior part of the base of this urinary bladder. So, base is freely related to the seminal vesicle, rectum in case of the male, and related to the uterus and the vagina in case of the female. So, relationship of the base is again short note for you guys. So, describe with a schematic picture the relationship of the base of the urinary bladder. That means this simple thing that you have to remember, no difficult or no rocket science things. So, it is related to two things. One is above part, lower part. Above part, it has a peritoneal relation. What peritoneal relation? It has pouches. The peritoneal is dropping and curving there. Rectovesical pouch, uterovesical pouch. Lower part, it has a, in case of the male, it is related to the seminal vesicle and the vas deferens. The vas deferens has a part which is dilated, we call them as ampulla. Before it joins together to make that ejaculatory duct. In case of the female, we do not have a vas deferens, we do not have a ejaculatory duct, we do not have this particular seminal vesicles. What in place of that there? We have this particular structure. We have this uterus, cervix part, and then we have this vagina which is related to this. So, these are the things that you have to keep in mind related to the relationship of the base of the urinary bladder. Along with that, base is pierced by, so three simple things: male, female and ureter. Clear? Remember that? Fine. In case of the male, neck is having this gland, we call them as prostate gland. It has a base of the prostate gland which is lying in here, and it has a diaphragmatic support which is present in here. We call them as urogenital diaphragm. If you have studied the diaphragm already, I don't know, we have a separate class on that. So anyways, this part which is related to this particular structure, we call them as neck. In case of the female subject, the neck is only where this particular urethra is coming down. So in case of the female, it is neck is not surrounded by this gland. In case of the male, it is surrounded by it. So this is what we have to keep in mind related to. This is a schematic, this is kind of Netter's pictures. This is bladder which you are seeing here. This is the neck part, apex part, superior surface, base, and upper part of the base, lower part of the base. And then you have the urethra which is dropping down. Surrounding over here is this organ, we call them as prostate. This prostate makes a bulge over here, we call them as uvula, which is a gland part. We are going to talk later on when you see here. Now coming to the female subject, the same thing, it is related to the posterior side. See that no this particular like seminal vesicle, no this vas deferens, no ampulla, anything is there. Rather than we have this part which is known as cervix, and then we have the vagina which is related to the posterior side of it, which is related to the base of the bladder, and it is pierced by structure which is coming in the side, forming related to the trigon of the urinary bladder. So this is what we are talking about. From the testicles, this particular thing which is going here, we call the vas deferens, going through this inguinal canal, going on the lateral wall, then it crosses over and reaches to the posterior side and going into this part. Once it is crossing over this part, it gets this particular ureter which is coming here. So see that this is the ureter where it is crossing over here. So it is crossing the ureter like this. So this is what we are referring back when you are studying this ureter or the relationship of the ureter over here. So lateral to medial, it is crossing over in case of the male subjects. So this is what we are talking about, bladder and the surface and all the related thing. Collapsed bladder, distended bladder. So this is the difference that we are seeing here. This surface was not there in here. We have this inferolateral surface. Now all of a sudden it pops up. Now it becomes anterior. So then we call them as antero-inferior surface. This one blending together, we call them as posterior and superior surface. So it changes with the distendability of this. Now this anterior surface of the bladder is lying in front of the anterior abdominal wall. So we have this anterior abdominal wall muscle, we have this particular thing which is present and directly over there. So we have seen that peritoneum which is lying on the superior part. So between this part, you see that, and the anterior abdominal wall, over this symphysis pubis, we have no peritoneal covering. So the bladder can be accessed through this anterior abdominal wall above this symphysis pubis directly without damaging this peritoneum. So this helps in doing a surgery. We call them as supra-pubic hysterectomy or bladder puncture. So you can reach to the cavity of the bladder, piercing this distended bladder. When it is distended in urine like this, you can directly pierce it and go inside this and do a surgery. Say for example, inside this urinary bladder you have a tumor, right? And this particular tumor cannot be negotiated through this urethra or through this path. It's a big tumor. So what we do? We fill up this bladder with fluid or let the bladder get filled up with urine and clamp it, stop it. This bladder is distended, the anterior wall is visible with imaging or clinical examination. We find this bony landmark. What bony landmark? Symphysis pubis. We cut the skin in front of the symphysis pubis. Skin, superficial fascia, we do not have that much of fascia, fat covering, we remove that, then we get this anterior abdominal wall. We cut these walls of the anterior wall muscles, then we end up into the anterior wall of this urinary bladder. This wall of the anterior wall we call the antero-inferior wall. We cut this anterior-inferior wall, then we get inside the urinary bladder. We do the surgery, remove the tumor, take out, stitch it and stitch this particular anterior abdominal wall muscle and then come out. So this surgery we call them a supra-pubic approach, above the pubis and going inside the bladder. So cystostomy or cystic bladder structures or bladder surgeries that can be done without getting or cutting or disturbing anything, pretty much easy. Peritoneum is not breached, you are not going to cut any structures related to it, so the organs is not hampered. So this particular things related to these operations, we can do it with anesthesia which is locally putting this drug over here. So we can anesthetize the skin, cut this, get inside, the bladder is insensitive to pain and go this. Clear? So this is how this bladder can be approached. And internal trigon that we have talked about, boundaries of the internal triangle, what is external trigon and what are the developmental relationship of the trigons of the bladder. We will talk that in embryological classes. We will be dealing with this trigon development in embryo. We will talk about them there. So this is what we are learning in this particular part. Now coming to the blood supply, the blood supply to this is coming from the internal iliac branches. With the name of the branches related to the bladder, we call them as vesicle. We have two sets of artery, superior vesicle and inferior vesicle artery, supplying the bladder from above, supplying the bladder from below. So this vesicle artery, besides it supplying the bladder, it supplies what? The ureter, which is supplied by this vesicle arteries as well. So this particular vesicle arteries is supplying these particular regions over here. Now coming to the venous drainage. From these vesicle arteries, blood is coming to the bladder and blood is going back through the vesicle veins. The vesicle veins drains into which vein? Internal iliac veins. Now this normal thing, which the bladder thing, which is going from this particular vesicle artery to the vesicle vein to the external iliac veins or iliac veins or common iliac veins to the inferior vena cava, to the heart. Addition to this particular veins that we are talking here is having a venous channel connection with this blood supply of a venous drainage or vesicle veins of the bladder with a venous set of the vertebral veins. So this vesicle vein has a connection which is with the backside vein, we call them as the vertebral veins. So between this vesicle vein and the vertebral vein, we have a communicating veins. We call them as Batson's veins. Getting it what I am trying to say? So this bladder, the blood supply from this urinary bladder going through the vesicle veins, inferior or superior depending on how much we have, ending up to these veins, iliac veins. This is normal thing. Addition to it, this vesicle vein has a connection with the veins which is related to the vertebral veins. So this channel which is communicating from the bladder veins to the vertebral veins, we call them as Batson's veins, B-A-T-S-O-N. So that Batson veins is valveless. Normally it is not transmitting veins to the Batson veins, but it can transmit when we are having an increased abdominal pressure. When we have increased abdominal pressure, coughing, sneezing, defecation, micturition, that time we have a negative pressure which is driving this particular small quantity of blood from the vesicle vein to the vertebral veins. It is going reversely, backflow. Why it is going in the backflow? Because it has no valves. It can go front, it can go back. So if you have a cancer on the bladder, that can spread directly to the vertebra. Is it possible? So the carcinoma of these, explain why. The cancer of the urinary bladder can directly go to vertebra. So CA bladder can directly spread to vertebra. Explain why. So you find this question. Explain why question. How the cancer of the bladder can be spreading to vertebra directly. And find the answer, come back with me, with the answer for me. Finding a logic or anatomical logic. Now coming to the last part of the urinary bladder. So what we have studied, the gross and the blood supply of the bladder, then we have the two nerves to talk here. We have the bladder controlled by two nerves, we call them as sympathetic nerves, other is known as parasympathetic nerves. So we have a muscle of the bladder, we call them as detrusor muscle. So the muscle of the bladder is innervated by these two sets of muscles and nerves, sympathetic nerves and parasympathetic nerves. So sympathetic nerve relaxes the detrusor muscle. That means bhalo gocchu, kore jao. It relaxes it. That means it is allowing the bladder to hold the urine. and parasympathetic nerve তাড়াতাড়ি করে ফেলো এক্ষুনি খাতা জমা দিয়ে দাও is contracting the detrusor. That means it is contracting the urinary bladder. That means urine আছে ছেড়ে দাও. So it is releasing it. So it's known as voiding. So one nerve is holding it, the counter one is voiding it. So sympathetic is a holding nerve and parasympathetic is a releasing nerve. This counter thing is balanced. So whenever this bladder is extended or distended, there is parasympathetic drive about going to the toilets, and the detrusor is contracted and bladder is emptying the fluid when till it reaches to a point. So parasympathetic is holding it up to, like for example 300 ml of the urine. We do not understand its urine is there or not. Once it reaches to the 500 ml, then this bladder is stretched and parasympathetic is super steady. এই অনেক হয়েছে আর পাচ্ছি না, ক্লাসটা শেষ করো, পালাবো. So what you are doing right now is sympathetic. Now moment class ends, parasympathetic. So going out. So this thing you keep in mind for now. The physiology part will be covered later on, or if required I can do the complex work for you to understand the different phases of bladder, holding capacity or unholding capacity, but that will be too early to talk about this particular blood supply and how this particular blood can be, cancer can spread from bladder to vertebra, find a cause, nerve supply to this particular bladder, sympathetic, parasympathetic, which is holding and which is voiding, parts of this urinary bladder which is present, like different parts, and trigon of the bladder that we must identify, and relationship of the posterior surface of the bladder in male and female subjects, or base of the bladder, and how the bladder can be approached without disturbing or damaging the peritoneum. That is known as supra-pubic approach.